All right, let's talk about musculoskeletal tumors. When you're faced with one of these in the clinic or on an exam, having a solid, systematic framework is absolutely non-negotiable. So in this explainer, we're going to build that framework step by step.
So, this is the core question, right? A patient walks in, you suspect a bone tumor, now what? We're going to tackle this by walking through the exact process an orthopedic oncologist follows, from the moment they see the patient to the final treatment plan.
Here's our game plan. We'll start with how we classify and stage these tumors. Then, we'll dive into the diagnostic workup. After that, we'll cover the essential surgical principles, see how we match therapy to the tumor stage, and finally, we'll nail down the key take-home messages you've got to know. First things first. Before you can even think about treating a tumor, you have to speak its language. You need to understand its biology and its potential. And for that, we need a standardized system that everyone uses. And that language is the GTM system, also known as the Enneking system. This is our foundation. And it's so critical because the final stage we get from this system is, without a doubt, the single most important factor that dictates our entire treatment strategy. Let's break it down. It's built on 3 pillars. First, G for grade. This is all about the histology. How aggressive do the cells look under a microscope? Then we have T for tumor. This tells us about its local spread. And the key question here is whether it's intracompartmental, meaning stuck inside one anatomical box, like a single muscle group, or extracompartmental. And finally, M for metastasis, which is pretty straightforward. Has it spread to distant sites or not? You put G, T, and M together, and you get your definitive stage.
Okay, so we've got the GTM framework. Now, how do we actually gather the info to fill it in for our patient? Well, that's where the diagnostic workup comes in. This is all about collecting the data, the radiology, the pathology that we need.
Imaging is our first major step. We're trying to really characterize this thing. What does it look like? Is it eating away at the bone? Is it lytic? Or is it building new bone, sclerotic? Are its borders clean and sharp, or are they messy and ill-defined? And crucially, where exactly is it sitting in relation to everything else?
And this is where we see our main imaging tools really shine in their own ways. X-ray and CT are the kings of bone. They give us incredible detail on bone destruction, any reaction from the periosteum, and they're perfect for planning the bony part of a surgery. But MRI is the undisputed MVP for soft tissues. It's how we see that extraskeletal component, the part of the tumor that is broken out of the bone, which is a huge red flag for malignancy. It gives us those precise borders we need. Now, to round out the workup, we might use something like a PET CT to look for metabolic activity and screen the rest of the body for metastases. But the final, absolutely essential step is the biopsy. You can't skip this. This is how we get our tissue diagnosis. And critically, it's how we establish the G, the histologic grade, which, as you know, is the first letter in our GTM staging system. Okay, we've staged the tumor. Now it's time to talk about getting it out. And let me be clear, the type of surgery isn't just a random choice. It's a highly strategic decision that's dictated by the tumor's biology, and it's all defined by the surgical margin we achieve. Think of this like a ladder of surgical aggressiveness. At the bottom rung, you have intralesional excision. Basically, you're scooping the tumor out from inside its capsule. Go up a step to marginal, and you're cutting right through that reactive zone around it. The next step up is wide excision. This is a real workhorse. Here, you're taking out the tumor plus a healthy cuff of normal tissue all around it. And at the very top, you have radical excision, where you remove the entire anatomical compartment that contains the tumor. And now, this is where it all comes together. We have our staging system and we have our surgical principles. The real art and science here is connecting the dots, creating a clear, logical algorithm that matches the right surgery to the right stage. And this table is the money shot. This is the central concept you have to understand. For a stage 1 tumor, that's a low-grade malignancy, the standard of care is a wide excision. But for a stage 2 tumor, a high-grade malignancy, you have to escalate to a radical excision. Now, stage 3, where you have metastases, that's a whole different ballgame that requires a very individualized, often systemic approach. And of course, surgery doesn't exist in a vacuum. We've got other tools in the toolbox, adjuvant therapies. These can be things used locally, like phenol or radiation, or systemically, like chemotherapy. They're all designed to work alongside the surgery to kill any remaining cancer cells and give our patients the best possible outcome. All right, let's wrap this up by consolidating everything into the most critical, high-yield points. If you remember nothing else, remember these principles. They will guide you through any complex case.
Okay, here we go. Number 1, stage dictates therapy. The GTM stage is your roadmap, always. Number 2, MRI is your best friend for defining soft tissue spread. It's absolutely crucial. Number 3, the biopsy is the final word. You need that histology to confirm the grade. And finally, burn this into your brain. Stage 1, low grade, gets a wide excision. Stage 2, high grade, gets a radical excision. Simple as that.
So I'll leave you with this to think about. In a field where the stakes are this high, how does sticking to this systematic approach, from staging to imaging to biopsy to surgery, how does that discipline directly prevent misdiagnosis and ultimately lead to better outcomes for our patients? It's the structure that provides both safety and success.